Hello everyone, wishing everyone a very happy IVF day, which is celebrated on 25th of July. I am Dr. Shweta Gupta. I am the co-director and senior consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital.
Hi everyone, I am Dr. Veronica. I'm a consultant in clinical genetics in Gangaram Hospital.
So, when it comes to the International World IVF Day, we thought that let's concentrate on the importance of genetics in IVF. And there are so many situations, in fact, not a single OPD goes where, we don't get a couple who needs a genetic consultation or a genetic counseling. They've had bad obstetric history. They've had some previous pregnancies affected with certain specific disorders or going through recurrent miscarriages with known genetic disease. Or disorders, and that is the place where we need geneticists. And I would like Dr. Veronica to tell us in detail that how the genetic department or geneticist can help us.
Thank you, ma'am. So now, as we know, the IVF world is expanding vastly. So what the upcoming thing in genetics is that we are now able to test the embryo before it is implanted, and this process is known as a pre-implantation genetic testing. In couples with a family history of a genetic disorder or in couples who are carriers of certain translocations, we can offer this kind of testing, and this is known as a PGT-M for couples who are carriers of a genetic mutation, for example thalassemia, or PGT-SR, which stands for pre-implantation genetic diagnosis with structural rearrangements, which we can offer to couples with recurrent miscarriages and where one of the partner is known to have a balanced chromosomal rearrangement. By doing this, we can help the couples achieve a normal pregnancy and a healthy outcome.
So, clinically, clinicians also have a lot of responsibility, because once they have gone through the genetic counseling and they've decided that, let's assume that the couple is a carrier of thalassemia and they wish to go through PGT-M, it may sound easy, but it's not that easy, because we need to know the age of the female partner, which is the most important determining factor in the success of the program. We need to know what is the ovarian reserve. If the ovarian reserve is very poor, then the results cannot come in one single IVF. They may need 2 stimulations. There have been occasions where I had to do 3 or even more IVF stimulations to actually produce enough embryos. And then there is the cost involved, because this is normally not covered under insurance in India. So patients have to pay from their pocket. But the positive side is that when they achieve pregnancy and have a baby through this procedure, the disease is eliminated from the family. So yes, I can recall that very recently one of my couple, they had a baby when they not only had a disease-free, thalassemia-free embryo, but they also went ahead and did an HLA typing because they wanted, their first affected child to be treated.
That is the beauty of the genetic testing, that it can affect not only a production of a healthy embryo, but also a healthy outcome of the sibling that was present before the baby was born. Another important area of pre-implantation genetic testing is prenatal genetic testing for aneuploidies, wherein we test the embryos to look at all the chromosomal aneuploidies so that we can help them for a healthy baby. And this is also offered in women who have a higher maternal age, or where the ovarian reserve is very low, or again where there was a recurrent pregnancy loss. So this is now very upcoming and is now being offered with a routine IVF cycles as well. Of course, the challenges of cost, as ma'am mentioned, remain, and another important challenge is the presence of mosaicism. So testing an embryo is not a very easy task. We need the presence of good geneticists, trained embryologist and bioinformatic analysis to test those embryos, also because one cell does not represent the whole fetus later. So when we do a particular testing in the embryo, a lot of times we need to retest the amniotic fluid to be sure that what we tested at the level of a cell was not mosaic, and then it is actually the final reflection in the amniotic fluid cells. So there is a chance of retesting, which we should always make the patients aware of.
So another, I think, aspect where we offer a pre-implantation genetic testing is when any one of the couple, male or female, are carriers of a translocation and which are, causing miscarriages. So if there's a known genetic cause of miscarriages, then yes, we can offer PGT-SR, and I think this is more commonly now being accepted. I'm seeing an increasing trend in couples who are more and more aware, and they're coming forward because they don't want to go through the risk of multiple miscarriages and DNCs. There's a risk, of damaging the uterus, so they want to, have this process of PGT-SR where they can have a healthy embryo and escape the miscarriages.
Finally, I'd like to just give a message that we can test the embryos for important lethal conditions and severe conditions. We do not aim at producing designer babies, we just aim at producing disease-free, healthy children.
So in the end, I'll say that genetics is of course not, in IVF only for PGT, but there are other, areas where we need the help of genetic department, like in males who have very severe oligoasthenospermia. Also in azoospermic men, especially obstructive azoospermia and non-obstructive, where Dr. Veronica will just tell us that what all tests we can, have it offered. And then there comes in very early, I think maybe unexplained miscarriages where we have not yet done any genetic testing for the couple.
So when we talk about male factor infertility, the first and important thing is to describe whether the azoospermia is an obstructive or a non-obstructive azoospermia. When we have a non-obstructive azoospermia, in that case we need to check for the AZFC microdeletion, perform a karyotype of the individual, but when we have the fructose which is missing, in that case we can actually test for the CFTR mutations and other some common mutations which leads to a CFTR related CVAVT. So in these cases we can actually help these families to produce a child by their own sperms because the condition is obstructive and they are able to father a child only by using a different technique.
So I think that there is a vast need of a very good, I would say, interaction or a tie-up with the IVF center and a genetic center. A very high-end and robust genetic center is the need of the hour in an IVF program. There are specific indications, and when they are used for the right patient at the right time, then the patients are benefited. So wishing you all once again a very happy, International IVF Day.
Happy IVF Day.